Yeah, welcome. Glad so many of you are here with us tonight. My name is Max Wolff. I'm a clinical psychologist and addiction researcher, and I'm a member of the science department at the Mind Foundation. And this is the first episode of the Zooming In webinar series within the Mind Academy. So the name Zooming In is supposed to convey the fact that we will have in-depth conversations with researchers and therapists involved in psychedelic therapy and neighboring disciplines. And at this point, it's time for a disclaimer. So when we talk about psychedelic therapy here, we always refer to legal treatments that take place in a professional clinical setting in a highly controlled context. We do not endorse unsupervised self-medication with psychedelics or the use of illegal underground therapies. Now, Zooming In is a conversation-based format, conversations led by different staff members of the Mind Foundation. Today is my turn. And our first guest is Rafael Lancelotta. Am I saying this right, Rafael?
Correct, yeah.
Right, Rafael Lancelotta, yeah, who will introduce himself in a few minutes or moments. We will have a conversation of approximately 60 minutes. And after that, we will have a 30 minutes Q&A. So please use the Q&A button to pose your questions to Rafael and me about today's topic. So the Q&A button you find on the bottom of your screen. And yeah, use the chat for technical questions, all kinds of comments, or just for chatting between you. And in the background, we have Sergio Perez. He's the director of the Mind Academy. He's helping us out today with the technical stuff. He will also post links to interesting papers, etc., stuff that we're talking about. So leave the chat open to catch those links, please. So now it's my pleasure to introduce Rafael Lancelotta. Welcome, Rafael. Great to have you here.
Thank you. Thanks for having me.
Rafael.
Do you want me to introduce myself? Or?
Yes. Well, perhaps could you say a few words who you are and what you do?
Sure. Yeah. So I got my master's degree in mental health counseling at the University of Wyoming. And I've been working for the last 2 years at an above ground psychedelic therapy clinic, working primarily with cannabis and ketamine, treating a pretty wide range of mental illness, but primarily trauma-related disorders, but also extending to depression and anxiety. And I'm also a board member of the Source Research Foundation. Our mission is to make psychedelic research more accessible to students in marginalized populations or underrepresented populations, and to provide funding so that those really amazing projects can happen. We are also supporting community grants right now, and excited to, if you want to post some links to sourceresearchfoundation.org. And I'm also the administrator of 5meodmt.org, which is a forum dedicated to conversations around 5-MeO-DMT and just an unbiased source of information for harm reduction around that substance.
Yeah, so speaking about 5-MeO-DMT, I suppose that's your scientific focus, your focus in your research. Could you say a few words about the academic research you've done in this field?
Sure. So this research started several years, about four or 5 years ago, working with Alan Davis and Joseph Barsuglia. We had data coming out from a study that was done at a clinic in Mexico that was using 5-MeO-DMT after ibogaine treatments. And we had data and we were able to compare the effects of 5-MeO-DMT to the effects of mystical experience that were coming out of Johns Hopkins psilocybin trials. And so from that research, we found that the intensity of mystical experience that people were experiencing with 5-MeO-DMT was comparable to a moderate high dose of psilocybin. And so that created an interesting data point that then led to a really big global survey study that I was primarily working on with Alan Davis. And from that large epidemiological survey, we got a huge amount of data that broke off into several other papers. And so we were able to get information about set and setting, benefit enhancement strategies, harm reduction, mystical experience, personal meaningfulness of the experience, and the interplay of all those variables in that. And then my work has also been in looking at working with Malin Utag out of Maastricht University. We've done work together as well in terms of understanding how this molecule is used in naturalistic studies, in naturalistic settings, and finding out what are the more positive ways that it's used, what are the negative ways that it's used, and what are those considerations as this molecule may be considered for, as we talked about earlier in this podcast or webinar, how can this be used in a controlled setting for optimal benefit? And so that's the focus for me. Going forward, the thing that I'm very passionate about is the therapeutic component, the human component, and how we can synergize that. I think 5-MeO-DMT is interesting to me for a variety of reasons, but I think more than anything, I'm really interested in how can we improve the people component to optimize all of this.
All right. Well, thank you so much for giving this overview over your exciting work. And yeah, I think we're going to come back to a lot of those topics over the course of the next hour. So today's topic is defining therapy in psychedelic therapy. Rafael, why is it necessary to define what's therapy in psychedelic therapy?
Well, I think that in the field, there's a variety of understandings of what psychedelic therapy is and what that means. I think going forward, as this field expands and grows, I think more and more, traditionally trained clinicians are joining this field and contributing and bringing what I think are actually really rich insights to the therapeutic process. And so I think it's important to define therapy here, because when we're working with psychedelics, the psychedelic drug is not, it's not taking the place of of human interaction. It's not taking the place of having in-depth conversations or developing close relationships with the clients. It's actually an adjunct to a very rich process that would happen anyway, right? So I think the ideal thing that would happen is that you actually have therapists who are very competent and very effective at doing as much as they can without the substance. But then when we introduce the substance, it really optimizes the process and can open things up for the clients in unique ways. So really, I think emphasizing therapy, because if you have a very competent therapist, it's not as much of a stretch to train them to add in the psychedelic component. But it is much more difficult for someone who maybe understands the psychedelic component and how psychedelic drugs help, but training them on how to do therapy can be very challenging, right? Because there's a tendency to lean so much more on the substance and lean less on relationship. So I think for greater efficacy, we can really focus on relationship and I think ultimately provide better models for the world going forward.
Right. So what you said, I think it may be a bit on a contrast to what is going on in psychedelic therapy research, where mostly there is a minimum model is employed, a minimum therapeutic model. So maybe, perhaps Could you explain a bit, like looking at psychedelic therapy as it's going on in current research studies, how much of that is really psychotherapeutic interventions?
Well, so it depends on what studies we refer to. I think the MAPS MDMA studies have they have a therapeutic component. They have a certain amount of hours before and after, and I would say even during the MDMA sessions, there's a lot of interaction with the participants. With the psilocybin studies, I think they have between 9 and 12 hours of preparation therapy, preparation sessions with the clients before the dosing session, and then there's an additional 6 to 9 hours afterwards, and there is follow-up for 1 to 2 months. So I think that there is some components of therapy, but because they're controlled research studies, it's like they're still cogs in a wheel, right? It's not as malleable. Where, for example, if we're really client-centered, then we can say, oh, well, this client maybe needs some more preparation work because we're observing these certain things that are happening, whether it's, maybe it's difficult for them to access a sense of safety, or maybe there's more pieces that could be worked without the medicine that could be good preparation for the medicine session. And then doing the medicine session from that very client-centered place where, okay, it's clear that you're ready, you're open to this, and then we can go in.
Right. That's of course hard to do from a standardized research perspective.
Exactly. Definitely. Right. Yeah. So that's, of course, when we talk about clinical design or research design, then it becomes difficult, right? Because then you have so many branches of the study, right? Well, they get 3 therapy sessions or 3 2-hour therapy sessions. And then, one group could then branch, right? And then we have this other group, and then it becomes too complicated. We have too many variables, and it becomes very difficult to show an effect.
Yeah.
So this is, I don't want to say this to put down clinical research, because I think that we're getting some really important data. And I think my hope in this conversation is actually to hopefully start to create a framework for what it might look like after these clinical trials have gone through, and then we can actually say, well, we can actually maximize the benefits that, although the drug itself has benefit and minimal therapy has benefit, we can actually do this even better. And it does require better skills from the clinician, but it also, I think, optimizes the outcomes. So.
Yeah, I guess I agree with that. I think clinical research certainly has its limitations, because we can never control all the variables, and we can never vary all the variables systematically, because that would be just too much work. We wouldn't have that much time and resources to do all that. But so what is there a database to, like in current research or in existing research, where we can already draw information from about how important psychotherapeutic interventions are in psychedelic therapy?
Well, there is anecdotal information. I think we talked a bit earlier about the paper that just came out that I worked on. That was led by Jason Woma and Alan Davis and Jeff Bathje. I maybe did not pronounce his name correctly, but
Bathje, yeah, I think it's Bathje.
Bathje.
Yeah. Can you post the link in the chat for this new paper from? Oh yeah, there it is. Yeah, thanks, Sergey.
So this paper was an attempt to start looking at that, to start looking at what is the impact of the therapeutic component, and hopefully start creating a framework for future research, and arguing for the importance of measuring more and getting more data on what is the therapeutic process utilized and how is that impacting the outcomes. And so in that paper, we did find that the inclusion of psychotherapy in addition to the psychedelic intervention had a huge effect, a significant effect compared to, psychopharmacological interventions by themselves. So I think that it's starting to make a case for that and make a point for that. And hopefully that, that starts to allow for people to look at it more closely.
Okay, so before we go more deeply into the meaning or the role of psychotherapy and psychedelic therapy, perhaps we should talk about the psychedelic experience first a little bit. Could you give us maybe a few sentences about what you think makes the psychedelic experience so therapeutic? What can patients learn from these experiences that they don't learn otherwise?
Mm-hmm. So what I think the psychedelic component brings to therapy is it's an opportunity for people to be able to pay a greater degree of attention to their experience. So I think that, for example, a lot of times people are coming to therapy because they have a lot of emotion that they are not able to feel. They don't feel safe enough to feel those emotions. They maybe have never had relationships in their life that provide a safe place for them to express emotion, to feel emotion. A lot of times that goes all the way back to parental relationships, right? Where parents just have not had the experience, and so that just gets passed on. So psychedelics, right? So I think that psychedelics provide an opportunity to utilize hopefully a strong existing therapeutic relationship and allow people to return to those powerful emotions and process through them. And by process through them, I mean feel them in the present moment, not feeling them as like a distant memory or something that is dissociated, but experiencing them in a way that's unrestricted and is happening right now. And I think that I like to use the metaphor with clients that if we're growing up and we're invalidated emotionally, it's kind of like we start out with like a fishbowl, and the fishbowl gets full of water and we don't really know what to do with it. So then, in our culture, we're like, oh, okay, well, learn how to meditate, take this antidepressant, right? Or, maybe I turn to alcohol or unhealthy relationships. And that creates a bigger thing. So now we have like a fish tank, and over time the fish tank gets full, and now we have an overflowing fish tank. And we're like, well, we've already tried all these things. Why am I so full right now? Why can't I deal with any of this? So I think what happens is psychedelic assisted therapy is an opportunity to begin to drain that fish tank. And so now there is not a backlog of stress and trauma and overwhelming emotions. We actually get to process through all that overwhelm, feel all that overwhelm in a supportive context. And then the next step there is that then people can experience things in the moment, right? Like right now, if I was angry about something, I might just say it. I might say, oh, I didn't like that. And I would feel safe enough to process that in the moment, to name it in the moment and bring it to relationship. And I think that is one of the greatest opportunities that psychedelic therapy has. And of course, there's many other aspects of it. But
so that's the most important one in your opinion: acceptance of current moment emotions, being able to feel with them and getting in touch with them.
Yeah, well, I think eventually getting to that place. I think clearing out the backlog of things that kind of gum up our system. They get in the way. And I think this applies to like people with depression, for example. To depression, it's like I'm so weighed down by sadness and overwhelm and I'm just shut down, right? So we have an opportunity to feel all of that. And that's where I think the therapeutic component comes in, because the therapy container allows for there to be this relational support that says, you know what, it's okay for you to feel all of these extreme emotions. It's okay. Like you can cry, you can scream, you can express yourself however you need to, that maybe you never were able to in the past. Sure. And so I think that connects to MDMA work with PTSD, connects to psilocybin work with kind of meaning of life and resolution of those cyclical patterns.
Yeah. Yeah, I would agree that modeling acceptance is really important in psychedelic therapy, right? In therapy in general, of course. Therapists should signal to the patient that it's okay to feel what they feel and what you feel. So this modeling aspect of acceptance of emotion, I think it's really crucial in psychedelic therapy. Apart from that, I think what's really special about psychedelic therapy compared to other psychotherapies and even acceptance-based psychotherapies such as ACT is that the psychedelic experience kind of teaches, or it can, in a proper context, it can teach people to let go of avoidance strategy, because it has this. It gives people this feedback that as long as you try to push things away, your experience gets actually worse. And so there might be some actually, I mean, I'm a behaviorist, so I would call it a reinforcement, a conditioning of acceptance going on that eventually enables people to revise avoidance-related beliefs, such as, what you've been talking about, emotionally invalidating family backgrounds, where people learn things such as boys don't cry, or when you get very sad, you lose control, or anger is dangerous. That's another thing that a lot of people learn. Anger means danger. It means I'm going to be beaten up or something. So these deeply felt beliefs, or let's say ingrained beliefs, they can be questioned and revised in this state. And I think that's something that's really special about the psychedelic experience, that it kind of conditions you into that state. Does it make sense?
Yeah, I think so. Yeah, I think that it does have that capacity, definitely, to help. I think that it increases that kind of plasticity in the brain, right? So it loosens some of those core belief structures and allows for people to just feel more freely from maybe more of a less inhibited place. Yeah.
So this kind of experience that we're talking about, I think it's being referred to by some in the field as emotional breakthrough experiences. You've also talked about mystical type experiences. So those two are currently, I guess, are the let's say the top horses in the race. Everybody has their bets on them as the likely mechanism of psychedelic therapy. Is there any any other, like less discussed about type of experience that you would say is really therapeutically important in psychedelic therapy?
Well, so I think that those, while those two have shown to have some correlations with positive outcomes, I think there's a lot more to it, and I think that we will probably start to see that there are more factors that will come out. Alan Davis has done some work on the quantum change model, which would be cool to check out. And I think there's a lot of elements that we can continue to see. I think there's the relational element that I think gets left out. And my criticism of the, people saying, well, the mystical experience or the emotional breakthrough, I feel like those are taken out of context, because if you have a mystical experience and you feel connected to the people who are supporting you in getting to that mystical state, then you actually are it's not just a mystical experience, but it's actually one that is then grounded in this reality. It's grounded with other human beings who are welcoming you back to this experience, to this life. And I think the same goes through for emotional breakthroughs, right? I think it's not about inducing an emotional breakthrough, which I think is what gets confused a lot, especially when you hear about underground practices and what people are, they're taking the research and just interpreting it in their own way. I think an emotional breakthrough is one that happens therapeutically, is one that happens from a place that is well supported, and where someone can gradually and willingly allow themselves to express all these emotions that have been held back, and to have them be witnessed, right? That is the emotional breakthrough, is finally like, oh, I can finally let go of all these defenses, and I can finally feel what I need to feel right now.
Share it maybe as well.
Sorry?
And share it? Is that
also? And share it, definitely. Yeah. So I think, yeah, go ahead.
What's your, this rings the bell of group therapy. I mean, in current psychedelic research, we see individual patients being treated by the therapist diet. And that seems to work. But isn't there, I mean, when we look at ceremonial settings, ayahuasca, the way that it's done, mostly done in South America and shamanistic practices, do you think that's a worthwhile thing to investigate? And does this work within a Western medical model to do group therapies with psychedelics?
I personally don't think that it would work to do group administration sessions. I think having cohorts can be incredibly helpful. And at the clinic that I work at, we did a pilot study with veterans. And the way that we structured it was that the veterans all had a therapy dyad. They received cannabis or ketamine-assisted psychotherapy that was somatically focused. And we also provided an integrated group. And in that group, all of these veterans were able to show up together, receive a group therapy. And that was all of them said that the group process was incredibly helpful. I think the limitations of something like an ayahuasca ceremony. So these shamanic ceremonies and models, they have also been taken out of context. The context in which they were produced is, you have a tribe that is, living in the jungle, and everybody lives together. Everybody is there together. You probably grew up with these people, and you are going to be seeing them tomorrow and the day after that. And so
it's quite different meeting a bunch of backpackers in Peru and doing it in
well, and
never seeing them again.
Right. Or even, let's say a group therapy, right? Like you do this group session, okay, so you have a bunch of people, you form these relationships, and then everybody goes home. I mean, or whatever, everybody moves on with their lives. It's a bit different where when you have maybe a therapeutic dyad, it's within a very clear context, and it's supporting the individual. And I think as a society, we're not quite there yet. I think we all have such individual traumas, and the places that we were neglected was not really necessarily in places of community. I mean, we need to reintegrate to community, but the places of core trauma are actually individual. They're often based on parental experience, early childhood experiences. And those are the traumas, and those are the experiences that have tied into later on. So I think, at least for me, I'm speaking more from obviously a trauma-based perspective, and so there's that. I think that group experiences can be helpful for maybe people who are generally healthy and are looking for some sort of community. And that, I think, is more of like a church context, right? Where you have people who are relatively high functioning, and maybe they just need community. They need to be able to feel like they can reconnect to life, to experience, right? Then I feel that it may be more appropriate. But I think for clinical indications, so much of these illnesses are based in isolation and neglect, that if you're in a group of people, are you really going to be getting the attention and the support that you need?
Yeah, I think it would be interesting to still try that and to look into it research wise. That would be exciting for sure. Speaking of trauma, or speaking of qualities of psychedelic experiences that are therapeutically valuable, what is there to say about challenging psychedelic experiences, or colloquial bad trips? What is there any potential, therapeutic potential in them, or should we try to erase them from psychedelic experiences? So I read some articles recently in Vice magazine. Perhaps you could post these, Sergio, in the chat, about current efforts to design bad trip-free psychedelics. A psychedelic that, I don't know what it does, but apparently it doesn't give you a bad trip anymore. That sounds good from an investor's perspective, maybe. What do you think as a psychotherapist? What's the merit of those endeavors?
I think that the challenge is how we define a bad trip. I think that in a clinical context, bad trips don't really happen. The research shows this. The research shows that in clinical studies that have the appropriate preparation, the appropriate setting, people don't really have bad trips. They don't emerge with trauma from these experiences. People report difficult experiences. I mean, there is a difficult experience, challenging experience questionnaire. That's a metric that is used. But the challenging experience doesn't necessarily dictate that it's traumatic in clinical settings. And actually, those challenging experiences often produce positive outcomes. So again, in therapy, for someone who is trained in traditional psychotherapy, part of therapy is, the whole point of therapy is not for clients to come talk to their therapist and then feel good. I mean, you talk to your therapist and you may feel uncomfortable. Your therapist might point something out that maybe gets you mad at them. And then you have something rich to talk about. Right? It's useful.
Yeah.
And the psychedelic process is the same.
Yeah.
You know.
Sure.
So I think the bad trip
may sound appealing to customers, to investors. Also, I mean, thinking about the idea of having psychotherapy where it never hurts. That sounds great. But it wouldn't work, of course.
It wouldn't work because I think at the root of all this is an avoidance, like we talked about earlier, avoidance of pain. And this, like you were talking about earlier, if we're going to look at it from a behaviorist lens, this is a habituation that actually I can feel pain. And if pain feels like too much, I know how to ask for help.
Yeah.
And that is the baseline of what we are trying to re-imprint, not only for individuals, but I think also for this world. I mean, as we look at the global events happening now, that I think that applies.
Sure. Yeah. Yeah. So avoiding pain, or trying to avoiding pain is impossible, but trying to avoid pain there is a consensus that that's one of the core commonalities of most mental disorders. And it's something that all psychotherapies do. All different schools of psychotherapy try to make patients engage with aversive content and reduce patterns of avoidance, whether they call it avoidance or not. You can call it resistance, or you can call it, what's the Rogerian term? You're a Rogerian trained therapist. What's the Rogerian term for avoidance?
Yeah,
is there one?
Resistance or avoidance. I since I work a lot in a somatic model, we often see it show up, like the way it manifests is through dissociation. Mm-hmm. Like our nervous systems have a mechanism of dissociation and use the endogenous opioid system to modulate that dissociation. Like there are studies with war veterans where they showed them films, war films, and measured that actually their bodies released endogenous opioids that would equal, a dose of morphine, a strong dose of morphine. And so our systems actually, especially traumatized systems, they're actually chemically managing on their own the pain, the level of pain, whether it's emotional or sense of overwhelm.
Do people dissociate in psychedelic therapy dosing sessions? Does it happen?
It definitely does. And that's not a problem if you are trained to track that. And that's where I think preparation is really helpful, because if you're trained to track dissociation with the client or with the participant, they begin to be able to be aware of, that I'm dissociating. And the fact that I'm dissociating is connected to this really uncomfortable emotion or uncomfortable thing. And those are opportunities to actually bring in the therapist closer, to lean into relationship, to move through dissociation, rather than traditionally what would happen is someone starts to feel a negative emotion or starts to feel uncomfortable. The dissociation comes up and they lose connection to the therapist. They lose connection to relationship, and that is reflected. They dissociate. But if they're dissociating and they actually have someone coming in closer and they can actually ask for someone to be there with them, then it begins to create a new pattern where the dissociation does not equal, or discomfort does not equal isolation. And then we begin to be able to move through the dissociation and have more access to those vulnerable places.
All right. So, in fact, that's another example of a difficult symptomatic reaction being a valuable part of the therapy.
Yeah, definitely.
Yeah. So, speaking of psychotherapy in around psychedelic therapy, so how can psychotherapy help patients make the most of such experiences, be it mystical experiences, challenging emotional breakthrough experiences? How does psychotherapy make sure that, or how can psychotherapy magnify the effect of those experiences?
I think that psychotherapy provides a consistent and grounding container for those experiences, and it provides continuity with those experiences with waking reality or ordinary reality. And I think that it provides that consistent place, and it provides an opportunity to experiment in relationship. Because I think that a lot of times people don't have a context or don't really have a place where they can explore a lot of that. So I think that it provides that continuous place and a container within which the psychedelic experience happens, rather than the psychedelic experience happening on its own or in an isolated way.
And when we look at different psychedelics, right, we look at psilocybin, which is most commonly used in current research, or LSD, ayahuasca, or even 5-MeO DMT, although there is not many controlled studies about that around. But considering that these substances they are all psychedelics, but they have different psychopharmacological profiles, and the experiences are markedly different. Do you think that psychotherapy should be different for these different psychedelics, or should it more be matched to the experience that people have?
Well, so coming from a somatic lens, I actually would disagree with you saying that the effects are widely different from one psychedelic to another. I think that if the psychedelic substance is taken within the context of a body-focused process, it actually looks very similar. There are flavors that are slightly different, like with cannabis versus ketamine. Cannabis tends to be more more direct, in the sense of like putting people more directly in touch with emotions, whereas ketamine is a little bit more non-dual, so to speak, where people have a little bit more choice, which is good for people who are more highly guarded. But ultimately the processing, and this is why I would say that the therapy is actually not that different, because the processing itself, the psychotherapy is the same. You're still supporting people in feeling their bodies. You're still providing that positive attachment. You're providing a regulated nervous system for someone to regulate with. All of those things are important, no matter if it's MDMA, ketamine, psilocybin, 5-MeO DMT. All of those things, are the same. I think when you start to see the big differences between these molecules is when you're using the high dose sessions, which I think it's debatable how, I think within some contexts they are therapeutically useful, but I think they are the utility of them is probably a little bit less useful than right now is being popularized.
Mm-hmm. Yeah. That also speaks to the idea that, imagining that for, let's say, high doses of 5-MeO DMT, that would almost inevitably lead to some state of ego dissolution, I would suppose.
Sure. Yeah.
And we know research connecting ego dissolution states to positive outcomes. So one might jump to the conclusion that let's just give people a super high dose of some fast-acting, very short-acting psychedelic, and it will give them the complete ego dissolution experience, and then they'll be fine.
Yeah, yeah. It's so worrying. So even as you say that, I like,
what's wrong about that?
Because you're forcing something. So ego dissolution is actually it's something that is accessible in an ordinary state of consciousness. I mean, we can dissolve the ego in relationship, right? By directing attention. People do it through meditation. People do it through many different practices. And the difference between doing it kind of willingly and through using different practices versus a high dose psychedelic is that the high dose psychedelic takes away all choice. You have no choice. You're going to lose your ego structure. It's just going to be gone.
Right. Yeah.
And so again, for some unique cases, that may be what's indicated. I mean, some people may need that. But I also think that the majority of, like, when you look at the general clinical population, especially when you're dealing with trauma populations, you don't want to do that. Because if you use a moderate or low moderate dose, you're actually giving people choice, and they can move towards ego dissolution and experience ego dissolution from a place of choice and still in relationship. If you blast someone off with a high dose of a short-acting psychedelic, the relationship gets lost. They're no longer in connection with anyone.
Yeah.
And they're just on their own on that. Yeah.
Yeah. So my, again, behaviorist take on that would be that, as you say, when people don't choose their actions anymore, or even their internal choices, how they engage with the experience, they can't learn from it in terms of operant learning, right? It doesn't, there is no chance of learning. If I do this, this happens, and if I do that, that happens, right? So they don't make the experience of, for example, consciously turning towards something aversive, and then finding out that it's not so bad, right? So that kind of thing. Like those,
I was just going to say, like, those big experiences can be resourcing for someone, like someone who just constantly has to withdraw, right? We can give them that ultimate withdraw experience, right? Like, totally out there. And that could potentially be resourcing and give someone more energy to then engage in the world. But I think that that's actually true for less people. I think what's true for more people is that we can use those low moderate doses to be engaged and to still access the subconscious material.
Yeah, I absolutely agree with that. It also resonates with, I have this idea, maybe it's controversial, about why we find these connections between ego dissolution and positive outcomes. I think it might be kind of like an epiphenomenon. The ego dissolution happens when people allow the experience when people allow it to happen. So when they learn to allow the experience to unfold without, for example, moving around or trying to tune it down or trying
distract,
to engage in avoidance strategies that are self-referential, like worrying, right? I mean, that always involves the self. So one could say that engaging in self-referential processes may sustain the self model in a predictive processing framework. And so you sustain the self. And this means that as long as you do this, as long as you avoid, and as long as you think of ways of how can I get out of this, or how can I get around these experiences, how can I exert control, as long as that happens, you're decreasing the chance of really dissolving your ego. And so when ego dissolution happens,
which is all okay.
Which is like okay, yeah, and it's part of the process.
Yes. And that's such an important. I just want to just because it's perfect. You put it perfectly in. But that's one of the things that's so useful. is to gain the awareness in that moment, is to say, oh, we can point out the avoidance. It doesn't, the point here is not to tell someone, oh, you're doing it wrong. You need to stop being self-referential, or you need to stop distracting yourself so you can dissolve your ego. It's actually, oh, wow. So this is really hard for you. And we can support you, and we can bring awareness, right? Not be dissociated in our distraction, but to start associating to when we distract, how we distract, and all of that. So I just wanted to
that's
add
important.
That piece.
That's important. Thanks. Yeah. And then, so if this is true, right? So more avoidance equals less chance of dissolving your ego. Then this would mean that the people in which we see with low to moderate doses full-blown ego dissolution are the ones who at some point managed to let go, or learned to.
Felt safe enough to.
Yeah, or felt safe enough. Yeah, safe enough to learn. So to put that all together.
Definitely. Yeah.
And then in that case, so that would mean the ego dissolution is not so much a value in itself, but rather an indicator of a learning process and of a but that should be controversial. Yes. I don't know.
But I would agree with you. Because, for example, people who practice meditation for a long, long time, or like someone like, let's say Ram Dass, right? He had experienced some ego dissolution, and then he was like, oh, there's something to that. I'm going to go learn how to do that naturally. But the value is that he learned that it's actually just always here. And, and so, like, let's say someone is doing psychedelic assisted therapy and they're not quite getting the ego dissolution. It just means that that's their pace. We don't have to force it. We don't have to say like, oh, well, you're not getting the thing, so we have to keep doing more and more and more. It's actually like, oh no, that's where you're at. So let's keep figuring out what's in the way. Do you need more relationship? Do you need more safety? Are you judging yourself, right? So then we can examine those things. And that's where the psychotherapy comes into play, where the psychotherapy allows us to examine those pieces.
Right. So
it was a great synthesis there.
Yeah, fantastic, beautiful. It's actually sad that we don't have much more time today.
I know. Maybe we can do a part 2. I don't know.
Yeah, we should. So as we're approaching the Q&A, maybe I would still be interested in hearing your vision, so to say, of how, if everything goes well, if there's no second Timothy Leary, or, we never know what the future brings, but if everything goes well, and psychedelics get incorporated into our healthcare system in Western civilization, what could it look like? How would you imagine integrated?
I love the idea. Yeah, I love the idea of these treatments being very tailored to each individual. So some people may come in and say, I really want to do psychedelic assisted therapy. And we're like, great, let's see where you're at. And that the process can, some people may need 3 months of talk therapy before they're actually ready to do a psychedelic assisted session. Or having the option to, let's say, for someone to receive some ketamine work in the very beginning, and then maybe that allows them to start, like we said, turning towards uncomfortable things and starts to develop relationship. And then, maybe they do an MDMA session, which deepens relationship, helps them confront more of that material. And then maybe down the line, just being able to incorporate different medicines at different points in someone's therapy, because these different medicines, like they do have their own benefits. I think they can be used interchangeably. And I think that, if a place only does psilocybin, we can still have good results. But, in an ideal world, is being able to bring in different medicines at different times, at different doses.
Right. So perhaps we should think of psychedelic medicines more like the same way we think of psychotherapeutic interventions.
Yes.
Right? So I don't always do exposure therapy even with an anxiety patient. I wouldn't do an exposure therapy in every session, but I kind of, I do what you said about the difference. I think what does the person need right now? And I look into my toolbox. So, perhaps it helps also to think of these substances as psychotherapeutic interventions and not so psychopharmacological agents as in a substitution framework.
That's exactly how I would approach it is using these as those little tools that, in the same way, like you said, exposure therapy, right? Or someone might, like someone who's trained in somatic experiencing might say, well, we're having maybe a psychotherapeutic conversation, and suddenly we see a little window and we say, oh, what if we spend a little bit of time feeling that in your body, right? Like, let's stop talking about the story and let's just feel it in your body. Okay, now you're overwhelmed, so we can pull back and we find resource, and then right? I mean, or maybe we're like, oh, it seems like you're talking about different parts of self. So then maybe we use some IFS things to thing. And I think that if we incorporate that same understanding to the psychedelic work, right? So not only are we using different therapeutic tools in the psychotherapeutic setting, but then we're also using different pharmacological agents to assist and support that process of the individual. And I think that and I think that could be great because you can be in connection with a psychiatrist who can be looking at that through their lens, and then the therapist is looking at it through their lens, and there can be a synergy there and a conversation between these two providers where it can be kind of discussed, like, well, would this client need this? Do they need that? And then the client gets to be a part of that conversation. And I think to me that is going to model what I think is a model that's going to help create a society and a world that is more integrated. And that would be the hope.
That sounds great. I think those are great last words for the conversation part of this webinar. Although I'd like to ask a last question that I'm planning to ask everyone who I invite to this webinar format is, could you name, just for our audience, could you name one academic paper or one book or book chapter that has strongly influenced your or enriched your views of psychedelics or psychedelic therapy and that you'd recommend as reading?
Sure. One book that I personally have loved is Allies for Awakening by Ralph Metzner.
Right.
It's a short book and it's to the point, and it is a little bit more focused towards the drugs themselves, but I think he raises some really important points, especially the concept of a dissociative dose. Mm-hmm. And he's one of the only texts that I've read that actually talks about that and talks about why a dissociative dose is actually not that useful. So I love that text. And another, as far as a paper that I really like, it's the title of the paper is Clinical Applications of Hallucinogens, a Review. And that was by Albert Garcia Romeo.
Oh yeah, that's a great one. Yeah.
That's a good one. And I I also really liked the recent paper that came out with Rosalind Watts, the proposed psychotherapeutic approach and integration for psilocybin. Trying to remember the acronym that they used, but it's based on ACT.
Connect and Body, right? It's ACE.
Yeah.
That's a beautiful paper. It's also, just as a recommendation for the audience, we have that talk that she gave on our conference, the Insight conference in 2019. It's on YouTube. Or perhaps, Sergio, could you post a link to that talk? That's really inspiring.
I'm on it.
Inspiring.
Just 1 second.
Right. Thank you.
Yeah. So hopefully those are good points for people to look at. And in terms of therapeutic models, I talked about IFS, internal family systems. I think is amazing for psychedelic work.
Yeah, fantastic.
So yeah.
All right. Thank you, Rafael. Yeah. So I think it's time we move to our Q&A section. So Rafael, let's look at some of the questions that people asked, and maybe you see one question that you find interesting here? I'm also scanning through them now.
Let's see here. Wow, there's lots of good questions.
Yeah. Which one do you like?
We could talk about this first question is good. I think we could answer it pretty quickly.
Yeah.
How do you approach developmental trauma with ketamine and or cannabis-assisted psychotherapy? What's the difference to single event PTSD? Thanks for that question, Jonas. So I think the approach to developmental trauma is, it doesn't matter so much the cannabis or ketamine. I think that the choice of one medicine to another is more of a decision that the client makes with a psychiatrist or for themselves. But essentially, for people who are more heavily guarded, ketamine may be helpful because it's a bit less of a direct challenge to the nervous system, whereas cannabis is more direct. People with developmental trauma are going to have many more relational triggers than someone who has a single event PTSD. So, and it also depends on when the single event happened in somebody's life. If the single event happened in a developmental stage, like early childhood, then it's going to probably affect their relationships throughout their life. And so probably that would be different. But if it's a single event PTSD or single event trauma that happened in adulthood, and that individual actually had really healthy attachments, like healthy relationships with their parents, healthy friendships, good friend groups, things like that, then the single event is going to be a lot more approached just in more of an exposure therapy type way, or for me, using a somatic approach to process however that trauma may be stored in the body. So typically a single event, if all other things are good, then then I think that is actually the big difference, is that with developmental trauma, you're going to have to go slower and focus a lot on relationship.
Great answer, Rafael. I have another interesting question here that's related by Clara Schüler. Thank you, Clara, for this good question. So would you see a connection between traumatized people that are highly dissociative and thus not in their embodied self, and the chance of ego dissolution? Would you distinguish between a cognitive ego dissolution and a more embodied one?
Definitely. So ego dissolution can also be a form of dissociation, which is one of the things that, that I would say is when psychedelics are used to produce dissociation, and ketamine at lots of ketamine clinics, not the one that I work at, but at infusion clinics, ketamine is often used as a way to induce dissociation or as the ego dissolution, right? The difference here, when So for some people, let's say someone is chronically stressed, they have chronic complex PTSD. Their nervous system has exhausted the dissociative mechanism. And so they're just kind of like fried, right? Their system is exhausted. So you give that person, let's say a high dose psychedelic or a high dose of ketamine, they're able to, in a sense, supplement that dissociation through an exogenous means. And that can give them more resource to then engage in therapy. And so that's where, I think that we're seeing those positive results is probably coming out of those types of people. The embodied ego dissolution is different in the sense that somebody who can be in their body and be able to directly experience ego dissolution, I think is more is going to be more helpful for integration. Whereas if you have someone who's experiencing it way out there, the integration is much more difficult because it's so separate from their body, from ordinary states of consciousness.
Thank you, Rafael. So I have speaking of the body, I have a related question here by Joas Muddy. I hope I pronounced that correctly now. Language and the psychedelic experience don't seem to match very well. It seems to happen on a different level. Do you think that's true? And if so, how do you connect the experience to talk therapy? Do you think too much talking can get people stuck in their experience?
So the concept of language and talking during psychedelic experiences depends pretty heavily on the dose. It also depends on the context. I think that there is a lot of value to silence and to going more internal during psychedelic experiences, as long as that's done intentionally. I think if someone, for example, the Johns Hopkins model where they've got headphones and eye shades on, it actually discourages connecting with the guides that are there, I think, on a subconscious level. So I think, at a high enough dose, that's all you can really do is actually go internally, because you won't be able to talk to anyone. But I think, I think connecting the experience to talk therapy is more like using the lower doses, helping someone to learn how to pay more attention to their experience, engage with their experience, and associate to their experience. I would agree that too much talking is excessive. I mean, I don't advocate for a therapist to be constantly poking at someone. I mean, that's not helpful. And that actually mirrors more of the anxious attachment style. If you have parents that are constantly, in their baby's face, I mean, that doesn't model healthy attachment. But I think it is important to model a healthy attachment in those experiences where the client is actually encouraged to come to the clinicians or to the guides to bring their experience to them, so that they're not just replaying, maybe an avoidant attachment style, like, oh, I'm facing difficulty, I'm just going to take care of this by myself, right? And so that kind of going internal can get in the way of creating a more healthy attachment. So that's kind of the thing to work on. I think it's a really important thing. Great question to separate those things.
Yeah, we have some really good questions. Hard pick, right? I have a good one here from Anonymous. Rafael, you wrote this paper about benefit enhancement measures or techniques, strategies. Could you explain a bit more about those in the context of a therapeutic process?
Sure. So that paper is specifically about the use of 5-MeO-DMT in naturalistic settings. So that means, people who are either using it by themselves or in small groups or in ceremonial contexts. And the purpose of that paper was to find out what strategies and behaviors people were using in order to maximize the benefits of that substance. So the usefulness of that in application to therapy is hopefully, if that substance gets moved into clinical trials, then some of these benefit enhancing techniques can then be utilized in those studies. And so we know actually we can use those to say, well, these techniques are going to enhance the drug effect. And then we can also then draw, my hope is then we can draw what we know works in psychotherapy and combine those two elements, which I think, for example, Roz Watts is doing with the ACE model. Hopefully that answers that question.
Yeah, I think it does. Maybe say, could you post, I don't know if you did that already, but could you post that paper or link to that paper from Rafael about enhancement strategies in the chat?
You can find the paper a little bit above the questions in the chat. I will post it again just under the question, all right?
All right, yeah, great, thanks. Rafael, any other questions here that you find interesting? We can also,
We can also what?
We can also, like, if we have, if we find a question interesting, we can also, we can also get the person in and ask them to elaborate on the question if we feel that's necessary.
Okay. I really like this one by Sean Lacob. There's research going on with different substances and for different conditions, but similar protocols. Do you think that when we have the choice of psychedelics for psychedelic therapy, that the choice of medicine will be best decided by therapist choice, condition, patient's personality, or some other factor? Will there be different therapeutic models for different medicines, or will it be therapist-based? Lots of good questions in there.
We briefly touched on that in the discussion, but I think we can... Yeah.
Sean, if you would like to, I could just invite you to the conversation.
Oh, great.
Wonderful technology, right?
Yeah.
Hi.
Hi, Sean.
I'm wondering when we finally get to the point where there's a choice, how is that choice best going to be made? In your opinion?
Yeah. So I think that it's going to vary. I think that having flexibility can be really useful. And I think, I don't think that it will be one or the other. I think it's hopefully it will be, the therapist will have enough education and will have enough reference that the therapist can help make a suggestion or put an idea out there that will actually be relevant to the condition or the diagnosis, that will be appropriate for the patient's personality. And I think that these are things that all clinicians are hopefully thinking about when they're conducting therapy in general, right? I mean, we were talking a little bit earlier, Max was talking about, when does he choose to use exposure therapy? And I think that it's important to actually, I think, I don't know if you want to speak to this, Max, for you, but I would assume that that all of these things are actually being taken into account and synthesized to help make a decision. So it's both the clinician is using their clinical knowledge and experience, and then also bringing in the patient's the patient's own thoughts and whether they feel like they want to do that.
Okay, let me turn it into a hypothetical. In about 3 or 4 years, someone comes in to see you with PTSD, and you need to decide whether cannabis, ketamine, MDMA, psilocybin, maybe even DMT. Okay. Do you think you'll be picking it according to which one you're most comfortable with? Or you're going to say PTSD, well, that works well with MDMA, or by the client's personality to see which type of flavor would suit them best, kind of thing, or a combination of this, and we still don't know. How do you think?
I think the primary thought is, where is this client at? What are they ready for? Is the client highly guarded? Are they, emotionally, are they highly guarded? And would something like MDMA be too intense, like being thrust into very close relationship with someone? I would not choose that, right? For someone in that state. But let's say they're very open to relationship and they're like, oh, I'm married to a wonderful person, and I've just had this trauma for years, and I have this stress that I'm carrying with me all the time, and I would love to be able to feel into this more deeply, and I really want to engage in this relationship, this therapeutic relationship, to work through it. Oh, then MDMA might be applicable, right? We do the preparation work and see where they're at, and then maybe MDMA is a good starting place, or maybe for someone like a long psychedelic experience, like 4 hours, maybe too much. So maybe we start with cannabis because their system is maybe well suited for a direct experience, but maybe not suited for a 6-hour experience like psilocybin. Or maybe not the intensity of an experience as 5-MeO-DMT, which has more of that ego dissolution quality. So there's a lot that goes into that. And I think that's why I'm really advocating for clinicians to be involved, because clinicians have the training and have the perspective to consider all of these factors and variables in order to make an informed decision that's going to be best suited for the client.
Thank you, Sean.
If you want to add to that, Max,
Yeah. No, I think I'm good with that answer. I pretty much agree. Thank you, Sean, for the stimulating question.
Can I throw in another quick question?
A quick one.
Why do you think there's so little research being done in cannabis as a psychedelic therapy model?
Well, to be honest with you, I think it has to do with the pharmaceutical industry. It's not a drug that can be patented at this point. It's a plant that can't really be, like, nobody can patent and say, oh well, we're manufacturing this special drug. It's not a synthetic drug. And in places, for example, I live in Denver, in Colorado, where cannabis is fully legal. You can't make money off of that drug. So there is, so actually right now the University of Colorado is starting a research study looking at THC and CBD in treating depression and anxiety disorders. But I think the reason why there's so few studies happening is that it's not a drug that that a pharmaceutical company is going to be able to make lots of money off of, or patent, or and in general, I think cannabis is often just overlooked and not really seen as a psychedelic.
Do you think, or would you say, Rafael, cannabis, as we speak about cannabis, would you refer to cannabis as a psychedelic?
I think that it is a psychedelic under certain circumstances. And I also want to say that with a caveat that I think that, chemists and pharmacologists would disagree. They would say that's not a psychedelic because it doesn't have 5-HT2A activity. And I agree that, the traditional classification of psychedelic or hallucinogen needs to have that. I would only refer to it as a psychedelic under the context that it does provide access to the subconscious, and it does produce that kind of altered state. So it is highly dependent on set and setting, the way that it's used, the context it's used, and things like that. So I think I would term it a psychedelic when it's used in certain contexts, but that varies for sure.
All right. Okay. I think we have time for two more questions. Is there any particular one that you find interesting?
I was just reading Sabine's comment about the group work.
Right.
I think those are good points.
I think this touches something that we've talked about before. This is Hannah asking, do you believe psychedelic therapy can benefit everyone? Are there certain groups of people for whom you would not advise it? And now let's not talk about psychosis and these things. I think everybody, although, I mean, not everything has been said about that, but we've been speaking about personality disorders earlier before this, before the webinar, and there were some interesting insights from you. So could you maybe answer that question with an eye on personality disorders?
Sure. So I personally don't believe that psychedelic therapy will help everyone. I don't think that psychedelics are going to be the magic pill that's going to eradicate mental illness. So I'll start out by saying that. I think certain groups of people that I would not advise psychedelic work for are people who, I think we were talking about narcissistic personality disorder. I think, and even I think intense borderline personality disorder in general, when you have intense personality disorder symptoms, I think that that really limits the relationship. And so the tendency is just to completely avoid. And the personality disorders are actually just highly active defensive structures. And when you introduce a psychedelic, those defensive structures get put into overdrive. And that's where you will see very extreme states like increased suicidality, increased, destructive behaviors, right? In an attempt to control. And we don't want that. We don't want to overwhelm the system. We want to meet it where it's at. So I think with personality disorder, we can do lots of preparation work, and it's possible that it can help some people with personality disorders, but it requires a lot of awareness. It requires a lot of groundwork when the person is grounded and not in an altered state. So definitely personality disorders, people suffering with psychotic related disorders, schizophrenia, schizotypal, that the psychedelic experience could make that much worse. And I see psychosis related disorders as it's a natural reaction to withdrawing from reality. Right, there has been an experience or has been something that the mind cannot integrate. Right, like someone has had an experience that is so big and so jarring to their lexicon for life that their mind just shifts reality around it. Right, so a psychedelic would potentially exacerbate that kind of thing and make it much more difficult to manage. I think those are the main,
Yeah. Looking at the time, maybe one last question, very quick question.
Okay.
Speaking as a medical, this is Hannah asking.
That's exactly the one I was
I think that's a nice last one. So speaking as a medical psychology student interested in training as a psychedelic assisted therapy practitioner, what advice would you give to me along with the next generation of psychotherapists? You mentioned somatic experiencing and IFS as training pathways.
Yes, I think both of those are really great foundational models. I do recommend completing a clinical degree. So I have an MS in counseling, which included practicum, included supervision, included internship. And for me, getting that supervision and close work with mentors who had been working in the field for a long time was essential for me in my development. And I think it helped me think about things in this clinical format. And then in addition to that, then doing something like somatic experiencing, IFS, these are modalities that have that are long-term. It's not like a weekend training. They're protocols that you are actually learning over time. So I think, and really like the best advice that I can give is work on just becoming a good therapist. Just become a good therapist. If you are a good therapist, adding the psychedelic is not too difficult.
Become a good non-psychedelic therapist.
Yes. Again, remember, psychedelics are non-specific amplifiers, and that includes a therapist. So if you're not a good therapist, it will amplify the bad therapist. If you're a good therapist, it will amplify your great skills, and so I think that would be my advice, and definitely, continue to reach out to elders in the field, to people who have maybe been a few years ahead of you in the field, and continue to connect with the community, and especially on the clinical side, like really don't downplay the importance of clinical skills.
Yeah, I would like to add to that I agree with everything that you've said, Rafael. I believe there is a consensus in the field that this is something for good therapists, and not just for people who like psychedelics. And regarding the specific therapeutic schools, I think you can probably, this is something that has been said a lot of times, is that depending on your therapeutic background, you see just that in the psychedelic experience. That goes for me as well. I'm a cognitive behavioral therapist, and what I see in psychedelic therapy is revising beliefs that don't work well. And that is something that is undeniable. Somebody else, the psychoanalytic therapist, would speak of lowering defenses maybe, or broadening consciousness to include previously unconscious conflicts or something like that. I think there are all therapies that work without psychedelics, they may work better with psychedelics. Would you agree with that?
I think so. And I think that it will also require more of a synthesis of these different models. I think I have experience and training in kind of a bit of a wide range of these different models. And for example, with CBT type models, I think there are aspects, like I think of CBT as a really great way of managing symptoms outside of psychedelic sessions, and a great way it has a lot of strategies to work with that. And I also think that, like if we're thinking of changing beliefs, the mechanism for changing beliefs is through new experiences, because beliefs are based on experience. So again, I think of experience as grounded in the body. And that's where, for me, I try to bypass and kind of move the cognitive stuff to the side and say, let's focus on your body. What do you feel now? what is this experience like? And that I find with a new experience, then the belief naturally changes and then the cognitive structure changes. So it's a bottom up. But it's important, I think, still. And all of these modalities have their place. I don't believe in saying, oh, CBT is trash or DBT is trash, or, they all have their place and they're actually all very useful. And we just, again, we have to figure out when to use which tool. And I think that is the way forward. And just like we want to accept all people and all of their parts, we also have to figure out how all of these modalities have wisdom and how we can integrate them into the healing.
Thank you. Thank you, Rafael. Thank you, Max. Before we go forward to the ending of this part, I have a question for the public. And there is an option where you can raise your hand with Zoom. And I would like to ask you to raise your hand if you would like a part 2 with Rafael Lancelotta and Max Wolff in this format.
That's a great idea. There
you have it.
Did someone raise their hand already? I can't see it. Oh yeah, there's a lot of people.
Wow.
All right. So I guess, Rafael, we have no choice but to come back at some point. Great. Yeah, looking forward to that.
I had a lot of fun, Max. I'm so glad that you joined for this because I loved getting your input and it felt really great to have someone who could relate to what I was talking about.
Thank you so much for joining, for being the first guest in this new format. I think, you've been really a great guest, and probably you get told this all the time, but you're a great talker in a positive sense.
Thanks. Thank you.
It's really fantastic. A really good time here. Yeah, so I guess it's time to say thanks to everyone also in the audience for attending. Thank you for these stimulating questions. This has been a lot of fun. Thank you also, Sergio, for holding things together in the background. Fantastic job. And of course, thanks, Rafael, for the great conversation. I guess we have no choice but to do this again. Do you have any closing remarks, Rafael?
No, just a lot of gratitude for both of you inviting me here. Sergio for reaching out to me and bearing with my sometimes difficult to get in touch with. Again, lots of gratitude for the opportunity I feel like it's an important conversation. What?
It was a pleasure to have you here.
Thank you so much.
It was a great pleasure. Yeah. We're also grateful. And before saying goodbye, I'd like to advertise our next episode. It's actually very much